Welcome everybody to our monthly webinar. Thank you for joining in. Today we'll be hearing from our experts on a topic called Technology-Enabled Primary Healthcare, Reimagining a Client Journey. And we'll be hearing from our experts from JPIGO. Also a few announcements. Our Global Digital Health Forum is on this December, both virtual and in person in Washington, DC from the 4th to the 6th of December. The early bird registration has been open and it is actually ending in 2 days on the 30th of this month. So kindly, if you have not registered, please take advantage of the early bird registration before it ends. Please allow me hand over to Joanne, who is our moderator today. Joanne, over to you, and wishing you a successful meeting.
Wonderful, thank you. Let's get these slides up for you. Great, well, my name's Joanne Peter. I'm the Director of Innovation at JPIGO, and it's a great pleasure to be with you all. So I would like to invite you to sit back and to use and I today on 2 health journeys. One of these journeys is going to be the traditional health journey that I'm sure that many of you are all too familiar with. But the second might be a little new. So let's start here. This is the start of our traditional health journey. Maybe it's a billboard, or maybe it's a poster in the clinic with a simple, generic message telling someone something about their health. But what if we could take advantage of the near ubiquitous phone ownership and use in order to send somebody just the information that they need at the right time? Just imagine how we could start to reach some of the most hard to reach clients. I'd like to introduce my colleague, Dr. Gatau from Afghanistan, who's going to tell us how this is happening right now through JPIGO Afghanistan in partnership with VIAMO. Dr. Gatau, please turn your camera on.
Thank you so much. Thank you so much, colleagues. And this is Ghotay Sadiq Yaqubi from JPIGO Afghanistan, working with the UHI project, Urban Health Initiative in Afghanistan. Thank you. Our journey from a dramatic start started from Samia. Samia has just had her first baby, and it was a difficult birth. She's discharged only 6 hours after delivery and accompanied by her mother-in-law. She's scared and in pain. She is not too sure that she should be doing and feels too embarrassed to ask her mother-in-law any question about her baby. Samia did not attend any healthcare awareness raising session in neighborhood, as her husband family feels that raising children is what women do, and the neighborhood is not safe for women to go to do. Samia wants to do the right things, care for her baby, and be the best mother possible. She wishes that she had an older, kind sister who could share practical advice for caring the baby. What was the problem that we were trying to solve? As you know, in August 2021, Afghanistan underwent a changes in the leadership that has resulted in a new restriction for women, including their education, employment, and basic freedom of movement. It was hard. It was a profound impact on how women are accessing healthcare, and a good example of that was the postnatal care, especially. As per estimation that less than 1 in 5 women receive any form of postnatal care in Afghanistan, and my country has the highest neonatal mortality, 35 in each 100,000 birth rate in the world, and it is too critical. We need to find new ways to provide services within this context and empower women to reach to these services. Literature has documented that importance of self-care, and there is a growing body of literature on self-care in humanitarian setting like my country. With a small strategic investment from GPIGO, we set out to design and test a simple post-natal self-care solution that will leverage technology. What was the solution? Learning from existing work with GPIGO, such as Hello Mama, the MCGL PNC self-care guidance, and other examples show that and enabled us to partner it with WIAMO organization to develop a simple infoline to provide self-care promoting messages to women for the 6 weeks after delivery. This mobile phone-based resources used interactive voice recording and it eliminating the needs for literacy, where women selected relevant topics to listen to from an interactive menu with both baby and mother-focused content. The person of Aisha, it was familiar in my country, a kind and lovely young sister was used to help formulate the content of the messages. The messages were available in both language and message in each week were tailored to the priority of the postpartum weeks. For example, we considered the weeks 1 and 2 for the key information about the pain management and wound care for the mother and for breastfeeding for the children, while week 4 includes the content on family planning and immunization for the both. The postnatal infoline was free of cost. The participant could easily receive that. They could access the menu at any time to listen to the more messages. And women were offered these services in 6 big maternity hospitals in the capital of Afghanistan, and they registered to participate before leaving the postnatal ward. What did we achieve in this initiative? The demonstrative project reached to more than 232 women, and nearly 200 women continued to participate in the infoline, and we had only less than 20% dropout rate. Women prioritize message on breastfeeding, on danger sign, on personal hygiene, and mental health as per their need. More than 50% of the women participated in an inline in a survey, and more than 84% reported that the infoline was not difficult to use. 2 out of 3 women would recommend this to the friend, and more than 80 found that the information was useful and were able to implement it and recommended self-care actions most of the time. Review of implementation, the dashboard of weekly engagement, and inbuilt survey results showed that this intervention is both acceptable and feasible in my country. Based on this initiative result, this intervention has been included in the year 3 work plan, and we aim to reach out to the more than 23,000 for PNC and 9,000 for ANC infoline. While we go back to the beginning, we had Samia. He has just had their first baby, and it was a difficult birth. She is discharged only 6 hours after delivery and is accompanied with her mother-in-law. In the postnatal ward, the midwife helped Samia to register for the postnatal self-care infoline. In the first week, she learned how to care for her episiotomy stage, prevent an infection through good personal hygiene, and she recognized that she did feel a little sad and overwhelmed at that. And she was careful for gave her baby colostrum instead of threw it away. Over the next week, Samia was able to engage in behavior that helped her recover from birth and provide the best care for her baby. Samia shared some of these tips with her sister-in-law, who has had a baby this week. She feels like the older kind sister with wise advice, just like Aisha. It was our journey from PNC in flying in Afghanistan. Thank you.
Thank you so much. So let me take you back to that traditional health journey that we were on. Its next step might be to await a visit from a poorly trained community health volunteer. But what if a community health worker making the rounds in your neighborhood was equipped with a device and a mobile app that could guide her on exactly which households to visit, to collect the right information, and to provide the right guidance and treatment? Let me introduce you to Arnold from our office in Tanzania, who will tell you how this is happening in partnership with ONA. Over to you, Arnold.
Oh, thank you very much. Good afternoon and good morning, colleagues. I'm going to pass you through the story of the work that we are doing in Tanzania to enable primary healthcare workers with technology. So Gertrude is a hero in this story. She is a volunteer community health worker. Gertrude is a much loved and trusted member of the community because of a sincere desire to help people. And that is how she got into this role of community health worker. It was a democratic process. Her job entails making household visits to offer health education and follow up on the health of clients. She's one of a team of 5 such volunteers who have been deployed by the local government to provide frontline health services in her village, located on the shores of Lake Victoria in Western Tanzania. The health indicators in a village fall below national baseline, especially in the areas of reproductive, maternal, newborn, and child health. And although the government has built a lot of health facilities, villagers are still not seeking the services in a timely manner. Community health workers like Gertrude strengthen primary health care by providing an important linkage between the facility and the community to drive demand for services and client adherence to their continuum of care once they leave the health facility. So what was the problem that we're trying to solve? Gertrude has 60 households in a brief, with each household having an average of 5 people. Gertrude serves 300 individuals, each having a complex set of healthcare needs. Gertrude has to plan her visits to households so that she serves people who most need her at a particular point in time. And even as she does the prioritization, Gertrude cannot afford to leave anyone behind. Now, balancing this set of complex priorities is very difficult for Gertrude when she relies on paper registers. Our solution, next slide, please. USAID Yangu and its predecessor project adopted OpenSRP, a mature global good mobile app for the Tanzanian context. Of course, we did this work with our technology partner, ONA Incorporated of America. The adapted system that we named Waja app follows Tanzania's Ministry of Health guidelines and has been redesigned for the Tanzanian health care providers. The name Waja, in fact, is an acronym for community health workers in our de facto language, Swahili. Gertrude is one of the end users of Waja app. She was provided a smartphone loaded with an app and given a 5-day training, in which 5 days she was taken through how to use a smartphone, how to use the internet, and all the way how to use the app in an effective manner. Waja app assists Gertrude by triaging her home visits and providing client-specific guidance on how to interact with the clients once she reaches the household. Waja app has digitalized Gertrude's work and assists her to do work by automating some of our work, actually. For example, sending targeted time-specific educational messages, and reminders to clients which are triggered by events or anniversaries. Gertrude supervisors also have been empowered because they can now see what Gertrude is doing in real time, and therefore better supervise the important work she's doing. What did we achieve? Within 1 year of deploying Open SRP, 400 people, 400 CSWs like Gertrude had managed to enroll 25,000 households containing in excess of 100,000 individuals. And each one of these 100,000 individuals has their own specific requirements. So you can iterate the 100,000 to see how much in terms of data we have essentially been able to digitalize. Client-centered community health services have been provided to these individuals. The Tanzania Ministry of Health within that year had designated the Waja app as the primary community health system to be used by all and scaled nationally. And to reflect this new scope, the app was now renamed to the National Unified Community System. National vertical programs beyond RMNCAH, like HIV, AIDS, and malaria, have already joined the effort, and they have added content to the app and are pursuing more aggressive use of the system. Implementing partners from other projects are also adopting the system. For example, we have recently collaborated with UNICEF. UNICEF is both a donor as well as implementing partner in some projects here in Tanzania. We have collaborated with them to deploy client feedback functionality on UCS, which enables client messaging directly with the client by pushing messages and reminders, as well as pushing quality of care type of surveys, so as to know the kind of service they receive at the facility. Again, all these are triggered by events. So going back to the beginning, Gertrude has transitioned from paper registers to the new digital tool. She's a pioneer in the ranks of a soon-to-be army of tech-enabled frontline health workers deployed for strengthening primary health care. Her work has been simplified for her, and her effectiveness has multiplied several fold. But most importantly, our clients now make better health decisions, and therefore their health results in their villages are much better. Thank you for listening.
Thank you so much, Arnold, for that example from Tanzania. So now I'm going to take you back to that traditional health journey. What's the next step? Now we might have to walk for an hour to get to a busy and understaffed primary healthcare facility. But what if, by investing in telehealth and other digital health tools, from the comfort of our own couch, we could reach a health provider exactly when we needed one? Let me introduce my colleague Anunya Jain from Japago, India, who will tell us how this is happening in partnership with CEDA.
Thank you, Joanne. Good afternoon, good morning, good evening, everyone. Let me start with a quote from Martin Luther King. Martin Luther King said, "Of all the forms of inequality, injustice in healthcare is perhaps one of the most shocking and inhumane." A couple of years ago, I would have spoken to you about a robust telehealth system for primary care delivery in India as a dream. But today I speak to you about one that's almost realized. So let me take you into the life of Sanjay from the district of Fatehpur in Uttar Pradesh. And Joanne, if you can make a couple of clicks on there. Sanjay is a daily wage worker who, like the average non-agricultural working man in the state, travels anywhere from about 6 to 10 kilometers on foot each day for work. When he's lucky, he hitchhikes on a friend's bicycle. His meager wage is just enough to ensure basic essentials for his wife and his 2 daughters. Access to routine healthcare is a remote reality for him, both figuratively as well as realistically. To bring this into context, Uttar Pradesh, the state that I'm talking about, in 2020 had only about 54% of the population that had access to a healthcare facility within 5 kilometers of their residence. But this has now started to change. Restricted access, limited ability to spend, and the lockdown of the COVID pandemic could have literally been death's knell for many across the entire country. In 2019, this changed. And unlike many of the solutions that you've heard today, the national telemedicine service called eSanjeevani was launched by the Ministry of Health and Family Welfare, Government of India. Now, in mythology, Sanjeevani was a rare magical herb that was used to save the life of a fallen hero in the Ramayana. And eSanjeevani is quite literally translated into that same magical platform for all of us as far as primary healthcare access and delivery is concerned in India. Unlike prior proprietary solutions, eSanjeevani was made available as a digital public good. It was hosted on a national data center on a virtual private cloud. It had subnets, firewalls, anti-DDoS solutions, geofencing restricting users from outside of India to access the system, and end-to-end encryption protocols. And all of this essentially made it easier for states to overcome barriers as they started implementing eSanjeevani. They no longer had to spend a lot on ensuring infrastructure in order to start a service like this, and could concentrate really on activation and operationalization of the service itself. But not just from a technology perspective, right? eSanjeevani was designed to deliver what the health system actually needed. It was developed for both access directly from home by a patient, as well as facilitated access to a provider through what we call the health and wellness centers, which are frontline primary healthcare delivery facilities which are built in the communities of the patient themselves. This ensured that gaps in digital literacy, access to mobile phones and internet did not unnecessarily create an inequity in the care access that was enabled through eSanjeevani. As in many other states, in Uttar Pradesh as well, there was a new cadre of healthcare workers that was enabled, which was called the community health officers. A multi-tiered system of hubs and spokes was put into effect. In Uttar Pradesh today alone, we have about 28 large and 4,000 small hubs, about 16,000 spokes, and we conduct 52,000 consults on a daily basis, something that we could not even have estimated when we got started with the platform itself. I still remember the initial days, the reluctance and the apprehension that we saw on faces of people like Sanjay and their healthcare providers. Today, that same has transitioned towards hope and belief that this is a system that has truly been made for them. But let me also not sugarcoat the pill. We've encountered several hurdles as we supported several governments, in particular the government of Uttar Pradesh in partnership with the Bill and Melinda Gates Foundation in the implementation of eSanjeevani. We continue to work on opportunities like using eSanjeevani as a tool to really build digital awareness amongst healthcare workers, improving the quality of the data that is being entered into the eSanjeevani system itself. We continue to strengthen the system to ensure the availability of drugs and diagnostics also happens at the point of care delivery, lest the system again then fall into the hurdle of a new access gap that gets generated. This is not the time for us to be complacent, nor is it the time to only criticize and lose hope as well. Albeit we do 52,000 consults, it's still time for us to reflect, re-energize, and recommit to our future of using technology-enabled primary healthcare to overcome the many gaps that exist in the system today. There are innumerable opportunities that still exist. The time to build digital awareness and health literacy through these accepted platforms amongst families, especially women and their families. Efforts to improve the quality of data in eSanjeevani and its mining with data science could really hold value as far as the future of population-based healthcare delivery is concerned. Training healthcare providers in soft skills for the digital world, introduction of decision support systems, care pathways, and intelligent care navigation are all essential steps to improve the quality and the continuation of coordinated client-centered care itself. we need to drive a deeper learning agenda as well that captures the effect on the outcomes that are put into effect with the use of a system like eSanjeevani, especially concentrated on what is the effect on costs, what is the effect on real world outcomes for patients themselves. So let me quickly end by quoting the motto that we have at Jhpiego for our digital unit, which is dream it up. The heart always wants a little bit more, and these dreams may just save lives, improve health, and transform futures. Thank you.
Thank you. Thank you so much. Right, so back to the last step in our traditional health journey. Maybe now we have to visit a pharmacy, and it could be on a hugely busy street in Delhi, and we need to walk 8 blocks through the bustle of the city to get there. Or maybe we have to walk 8 kilometers on an uneven road. Or maybe it's a 5-hour line at the pharmacy window in a government-run hospital. But what if an ePharmacy could deliver the testing and treatment that we needed securely and discreetly right to our doorstep? Let me invite my colleague Daniel from Kenya to tell us how this is happening in partnership with Ardere and MyDawa.
Yeah, so thank you, Joanne. And just speaking from my colleague Anunaya, Lupita Nyong'o, a Kenyan actress and Oscar Award winner, once remarked that your dreams are valid. And I just want to share a short story about how Lucy's dreams have become valid within a very short span of about 6 years. So I met Lucy around October 2017. And back then, we just began the second year of a flagship 4-year project where we were tasked with introducing and scaling up oral pre-exposure prophylaxis for HIV prevention in Kenya. And as part of our efforts to design successful strategies, both for demand generation as well as service delivery, we conducted ethnographic research with potential users. And that is how I met Lucy. And this is what she told me. This prep you're telling me about is exactly what I need. I have a 5-year daughter who I left at home with my mom. She's my everything. And that is the reason why I do what I do. I want her to grow up and become a doctor like some of you. And I want her to become someone in life and not a sex worker like her mom. This prep can help me to realize my dreams. But I am confined to this brothel where I work, and my madam cannot allow me to go for that prep because she will lose money that day, and I also won't be paid. If only you could bring it here, anytime that I need it, I would be willing to use that prep. I lacked an answer for Lucy because at that point, that was a huge predicament. The government of Kenya had just introduced PrEP, and it was largely restricted to health facilities. And for Lucy to get her PrEP, she needed about $3 for her bus fare. She needed to spend about 2 hours for her commute to the clinic and another 2 to 4 hours at the clinic, queuing up and waiting for her turn to get her PrEP. Notwithstanding the fact that she could also face some stigma that would emerge probably from providers or some of the fellow clients that she would be with at the clinic. And with that in her mind, she remarked, "Kama ni mbaya ni mbaya," that is a Kiswahili word that simply means, let the worst come. But a lot has changed within the last 5 years. And today, Lucy can get that PrEP from the comfort of wherever she is and wherever she finds convenient. And all she needs is simply her phone. And coincidentally, this is her tool of trade that she uses also for soliciting clients. So all Lucy has to do is scroll through her phone and open the MyDawa application. So in Kiswahili, MyDawa means my medicine. And MyDawa is Kenya's first online pharmacy that is partnering with Jhpiego, Ardere, and University of Washington, and through funding from the Bill and Melinda Gates Foundation to implement this pilot program. And through her phone, Lucy can be able to book an online consultation with a clinician at Maidawa, and she can be able to order for an HIV self-test, which she'll be able to pay for roughly about $2 through a mobile money application known as M-Pesa. And the test, together with her prescription, will actually be delivered in under 4 hours. The package is also branded Maidawa, and it's difficult for anybody to tell what the contents are. And it could be similar to any other products, including pain medication or skincare products, and thereby eliminating some of the stigma that has been associated with PrEP. So all this has been made possible through a combination of several acceleration levers. So first, we are applying frontier technology solutions. And in this case, we have this telehealth platform, which provides this interface for a client like Lucy to communicate with clinicians, and thereby eliminating the need for a physical visit to a health facility. Secondly, this model is banking on Audea's Health Pass technology that uses artificial intelligence to support the clinicians in the interpretation of the HIV test results. And thereby, this provides an assurance of quality and gives confidence in the results. And finally, this model is employing digital demand generation approaches and market-based solutions to respond to a need for client-centered services that are convenient. So through a combination of all these different levers, Lucy is able to easily access her PrEP from the comfort of her brothel. And all this is delivered in a way that is convenient, seamless, and discreet through a trusted and single point of contact. Yeah, thank you.
Thank you so much, Daniel, for that story. So what we've discussed today are a number of examples that are happening across Jhpiego with our partners, and I'm sure that there are many, many other examples like this from those that are on the call. But the challenge to all of us here today is, how do we take what are these examples of individual steps within the client journey that are happening in different countries around the world and weave those into a single seamless end-to-end client journey in a single country? Because that is something that I think we still remain to see. And it's going to take all of our expertise in design and technology, and critically in strategic partnerships, for us to see that happen over time. So I will invite all my panelists to please turn your cameras on, and we'll have a little bit of discussion amongst ourselves. And then we will save a bit of time at the end to answer questions that have come in from the audience. And I will also say that we have noted our technology partners throughout the conversation, many of whom are on the call today. So if there are questions that come up that you might also want to answer, you are also please welcome to chime in the chat, or even put a hand up and you can unmute and answer, because we want to recognize the wonderful collaboration that has been so important here. All right, so first of all, let's just say, you know, a lot of these innovations are emerging from the private sector. Many of these are for-profit organizations, and Jhpiego, of course, is a non-profit, much more familiar with working in the public sector. So I wanted to ask my colleagues here today, how do we grapple with the different mindsets that sometimes exist across public and private providers, and how can we get these different actors to work together most effectively, which is what we need to create these kinds of seamless client journeys. So perhaps, Daniel, I can ask you to start, and then others are welcome to chime in.
Yeah, thanks, Joan. And I think, as you rightly put it, some of these solutions, like what I did present, are actually available within the private sector. And certainly, I think the mindset shift really becomes quite critical, because, like in our case, we are working with some of the private providers like Maidawa, who are providing an excellent platform. And they bring to the table technical expertise, a trusted brand that commands a huge market share. So in that sense, we see also that it's a scenario where we are both also bringing something to the table, in the sense that from our side, Jhpiego, with a history of strong clinical training a lot of experience navigating particularly the policy and regulatory space, as well as a deep understanding of what happens, particularly as far as clinical and implementation standards are concerned, and also experience, like for our case, implementing PrEP in the private sector. So a combination of these different strengths that we bring from the public sector, as well as what our partners in the private sector bring to the table, has been quite helpful in essentially coming up with a hybrid model around what works best. I would be lying if I say that it's simple. It's not easy, but I think it takes time, that as time goes by, and essentially also it's quite important to have a common vision of what you're working towards and what you're building towards. And of course, with that common vision and the appreciation of the strength that everybody brings to the table, then you're able to have a strong marrying of the different synergies across the different team members.
Thank you. Would anyone else like to chime in on that? AJ, go ahead.
Yeah, I'll just quickly jump in, since the intervention that I spoke about did actually come in from the government. And I think one of the key pieces that we discovered as to why eSanjeevani really worked as the innovation that the government really launched was that besides focusing on the technology aspects of it, there was a significant effort that was put into building two other parameters that are almost essential. One is leadership and governance, right? So in every state, there was a program management unit that was almost put together that ran the program in many ways, right? And so that was really important. And the second one was really building locally led capacity itself. And so we collaborated with an academic partner in the state of Uttar Pradesh to really ensure that that gets established as a center of excellence that can then continue to sustain all of the capacity building exercises that were ongoing, potentially as parts of projects for us, but then can be incorporated into the way of operations within the state itself. So I thought both of those aspects were really critical in order to ensure that whatever we do gets sustained and scaled within national systems as well.
Thank you. So I think there's two different sets of stakeholders that are really important to acknowledge.
Hey, Joanne, I think we lost you there for a little bit.
I'm back. Never happened to me before on Zoom, but always has to happen when you have an audience, right? Anyway, I'm not sure how far you got in that question, but I was saying two different sets of actors whose needs we really need to accommodate, both clients and health workers, of course. And so I wanted to ask the group, first of all, what measures have we taken to make sure that clients' needs are really accommodated? And then let's look at it from the health worker angle as well. And what do we do to make sure that health workers are also a critical part of the conversation? So Dr. Gatai, if I could start with you, thinking a little bit about the client perspective, what did you do in Afghanistan to make sure that you were really meeting your mothers where they were?
Thank you so much. Yes, as I mentioned in my story, there is a significant change in the government in Afghanistan, and we faced all women, especially women, mothers, newborn children, faced with different challenges, especially access to primary healthcare services in Afghanistan. And it was the main issue we focused on, how to reach to them, how to provide them the very critical services, because the PNC is very important part of mother and newborn life. We started this program to reach out to those women they do not access to the health facilities physically, and especially reaching out to those women they are not literate. And considering this, we focused on the PNC infoline, self-care infoline, and we provide those practical messages. It is convenient with our culture, and it is culturally accepted within the country, and also it is part of a practical work of those women. They can do it in their home. They can do it with a little modification on their behavior, and it helps us to target their needs. And based on that, we consider the PNC info line establishment with our VIAMO colleagues, and it is really a very well accepted initiative within women. And we have seen that based on this findings, we plan to have the ANC info line as well. And nowadays it is considering the sequence of the care, starting from ANC, receiving the specific messages to the mother, how to deal with the danger sign, how to know what is happening with their pregnancy journey, and how to connect them to the PNC. Because of this, we received a very well accepted finding from our online survey, and now my colleagues from VIAMO is also here, and we reached to many women. They do not access to the services physically, and now it is a good initiative to improve this within the country, and now we are planned to expand it to other cities to reach out to those women, because our first initiative was only in capital of Afghanistan, in Kabul, and for a specific and in a specific tertiary level hospital. Over.
So I can jump in?
Yes, please do, Arnold.
Yeah, okay. So for us in Tanzania, in terms of how we get everybody committed to the process, we try as much as possible to make sure that everybody participates fully, and people need to be enabled properly. You will see that, for example, when we do a lot of advocacy with the ministry, with local government, the regional cancer health management teams, in terms of planning around deployment, working with them to prioritize where we should expend effort. As you know, unfortunately, we cannot do universal coverage. So we plan with them where the pain points are and where such an initiative can have best results in their areas. Then in terms of the CSWs, we actually use the platform that we have built to make sure that they are fully empowered. We give them 5 days training. The first day turns out to be an orientation of how to use a smartphone, take care of it, how to use the internet. I know it sounds strange, but those are new things for most of our CSWs. How to go to Play Store, how to download this app. And then we have 3 days of classroom training, followed by the 5th day being a practical training session where we get the field and work with the people. In terms of the client, who's the beneficiary after all, whatever we do must appear to be of benefit to her or him. And that comes in the form of them getting this personalized service. You know, when they receive a message around, which is so well targeted to the specific time of their pregnancy, for example, or the age of the child. Maybe the baby started toothing and they get a message around toothing issues about babies having, health issues around toothing. For them, it's important. And so using those kind of soft touches and hard approaches, we have somehow managed to get everybody committed to the process. Over.
Thank you, Arnold. So I'd like to encourage people to put questions into the chat. We'll have one more question to the panel, but please do put any questions into the chat. And again, tech partners that have joined us, you're welcome to also chime in on questions. So the last question is this, of course, the technology, it's normally the easy part, right? There are a lot of other systemic challenges that we need to overcome in order to try to bring these kind of reimagined client journeys to life. So let's talk about some of those systemic challenges and what are we currently doing to tackle them. So, let's start with you, Daniel, chatting about perhaps some of the policy and regulatory challenges that you have had to grapple with. AJ, I'm sure you'd like to chime in. And then Arnold, maybe you can talk a little about some of the conditions of community health volunteers in Tanzania and some of the advocacy around health workforce that also has been required. So Daniel, let's start with you.
Yeah, thanks. So certainly, I think while this model that I did talk about holds a lot of promise, and we're seeing lots of potential, there are several regulatory barriers that we have to overcome. The first one being that delivery of pre-exposure prophylaxis through telehealth services is not part of the current standard of care. So that essentially entails a change of national policy so that this can be integrated and to become the standard of care. And already there is a lot of policy advocacy efforts underway towards addressing that. The second challenge when we worked on this model is essentially working towards a lot more self-care. We used HIV self-tests. And this isn't the delivery process. A lot of clients in Kenya use HIV self-tests. Unfortunately, HIV self-testing is not yet recognized as a diagnostic test within the national guidelines. And even that aside, recently there have been a lot of price hikes for the HIV self-tests, pushing it beyond the boundary of affordability for a number of clients. What we've seen historically, when HIV self-testing was introduced in the country, there was subsidization, which encouraged uptake. So with the exit of subsidization, the demand has also plummeted. So I think that's a challenge to deal with. And finally, is a question around training. Just tying back with the first point you did say, a lot of training, for example, for providers is rooted in work in the public sector, where people are supposed to be offsite for, say, 2 weeks. To be trained on HIV testing, spend another 1 to 2 weeks doing observed practice. This is difficult in a private sector setting where any time lost is also profits lost. So I think part of the effort we have done is really to work at abbreviated training curriculums, taking advantage of module and online training to pass the training content. But certainly also all this has to be included in national policy and their efforts towards addressing that. Thank you.
Thanks, Daniel. Let me quickly chime in. And I'm going to chime in with 3 questions, actually, that whenever we introduce a technology intervention, I think all of us need to be very, very cognizant about answering. The first one is, Daniel, as you very rightly said, what does it really take for healthcare workers to use the technology as it's being intended to be used, right? And so what generally we've seen happen is capacity building for healthcare workers, especially for technology interventions, happens for that technology intervention itself. And so it's that one more app that's taught to them, or it's that one more diagnostic device that's taught to them, and it's never thought of holistically as far as the way that they practice is concerned. And so we've started to think about capacity building in terms of 3 mechanisms. So one is the technical capacity building for the solution itself, any kind of capacity building that needs to then happen from an administrative perspective so that they can manage their workflows within the presence of this technology better. And third one is really the skills that they need, especially away from the core use of technology, but the clinical skills that they need, as well as the soft skills that they need in order to be able to use that technology better, I think is key. So that's the first one. The second one is we're again starting to realize that technology interventions usually bring with them some systemic inefficiencies. Very simple examples are ensuring that your internet is up every single day, adds a little bit of a checklist to your job for eSanjeevani as well, and then that doesn't allow you to do some other work that you were doing during that period of time itself. And so again, understanding what those systemic inefficiencies are that get introduced into the system, and then planning systemically for them to ensure that there is enough appropriate task shifting that happens, or enough support that team members have, especially from a perspective of on-ground supported troubleshooting, is important. And then the final one is, what are process changes that are required so that healthcare workers can implement the technology as it's being intended to be used as well. And so do they then need job aids? Do they then need enough monitoring and supervision? Do they then need to have enough data being monitored so that effective governance can be exercised? And so I think broadly those are three pieces that we've at least learned to add to all of our digital interventions as we start introducing them into the system itself.
Thank you, AJ. So Arnold, do you want to chat a little bit about some of the systemic health workforce challenges in Tanzania? And then we have two questions, it looks like, in the chat. Go ahead, Arnold.
Yeah, sure. I'll talk in terms of our national scaling effort that we are now engaged in. As we scale nationally this app, we of course work with government, and as opposed to how we started, government is very process-oriented. Decision making is usually the consensus. Everybody has to be in the room. So to get everybody in the room, everybody must be available at that time. So it is slow. Getting everybody available in a certain specific room in Tanzania at the same time always is a challenge. We also have to look at we think of it as that going government might be much cheaper, but our experience of having been there, working with our technology partner is actually private sector, and now that we go for the government national scaling, we find that it's not necessarily true that it is always much cheaper. There is costs which come in with collaborative work that went there when we were working alone. But of course, it provides a very good platform for building sustainability when we work like that. About the costs, one of the highest recurrent costs that we have in keeping this system going is the cost of airtime credit. Buying airtime credit for each community healthcare worker and their supervisor, especially when we go to national scale, it's quite a big cost. And right now we are exploring ways of doing it in such a way that will be manageable by government. For example, we are looking at strategic hosting with telco that can also provide the internet at zero rating. Zero rating openness therapy traffic. That is the way we want to go, because if we were to if all the technology, the implementing partners were to suddenly require government to pay all these airtime credits, it simply would crash down. So we are working with government to make sure that we have such a strategic hosting in place. We also have the issue that when you have these community health volunteers working on this platform, they are essentially unpaid. They get a stipend, yes, but they are essentially unpaid. So keeping the morale up for them is an important consideration. And we try to do that through our supportive supervision. We do a lot of supportive supervision around the implemented system, and during the supportive supervision, we don't only look at integrity and fidelity of the system, but also look at quality improvement of the system, how it's being used, and also building morale of the community volunteers. I hope you heard that, because where I am, it's quite rainy. Over.
No, that's great. Thank you. We've got just a few minutes left, and I see some questions have come through in the chat. So since you were just chatting, Arnold, I'll give you a little pause, but let's ask this one, which says, those that are marketing direct to client digital projects, the colleague says, I have found that near constant marketing is required to keep user numbers up. has Jhpiego had a different experience or found any solution to this marketing need? So AJ, you mentioned, I don't know, 56,000 consultations a day. That's a huge number. You know, what sort of marketing is being required to drive that? Daniel, what about the marketing to use the MyDawa service? Tell us a little bit about our experience.
Yeah, just very briefly, I think you're right. There does need to be a constant guidance that is provided on keeping this eSanjeevani service as first point of recall. And so there's a variety of information, education material that's posted at point of care, which turns out to be the primary mechanism in which patients actually end up using the system. And the second one is really communicating success stories and communicating stories of change and good outcomes that patients have had. And so we've experimented with both of those. There's a third angle that the government has really employed, and that is drives. Right, so they have camps that are organized where eSanjeevani consultations for particular disease processes are highlighted and are made available. And so yes, there is a need for this constant churn of communication that does need to keep up, especially as far as the demand side of the equation.
Yeah, so certainly, Joanne, there's the need for that constant investment in marketing. And since we have Maeve from MyDawa on the call, I would also just invite her, she could speak to this. I don't know, Maeve, if you're able to speak to that.
I think you need to be unmuted by the host. So let's see if that can happen. Okay, you're unmuted, Maeve. Go ahead, and you'll be our last comment.
Hi, thanks, Daniel. I'm Joanne, and everybody else. It's been a wonderful presentation. I really enjoyed it. MyDawa does a significant amount of marketing around this campaign, and actually, interestingly, this morning we have started looking at the data in comparison with the number of initiations, because our initiations onto PEP and PrEP are increasing consistently over time. However, our marketing spend is not increasing consistently over time. So our marketing spend is staying about level. However, initiations on a weekly basis are increasing. So we're also interested in understanding what's the correlation between the spend that initially needs to happen in terms of marketing, which, yes, was quite significant and was quite large to get the word out there, and then how much happens after that by word of mouth and by repeat customers, et cetera, who continue to use the service post us not doing any marketing anymore. And this is something Daniel and I discussed this morning as well, is looking at, if we pull back that marketing spend, which we're looking to do for the next quarter, to understand, will the initiations remain constant or will they drop? So it's not something we can answer just yet, but the trend we're seeing is the longer the service provision is in place and the more wider spread knowledge there is of it, the continuous increase in numbers of initiations we're getting are.
Thank you, Maeve. So I am so sorry, but we have run out of time, and there were a few questions that we didn't get to. So perhaps folks can quickly just type some answers in the chat to those. But otherwise, I would just like to thank everybody very much for their participation and coming on these journeys with us. And we look forward to many more conversations with all of you on the call about these topics. I'll pop my email in the chat. I'm very happy for folks to reach out. Thank you all so much.
Thank you, Joanne, and our speakers today for this wonderful insights. We look forward to responses in the chat for the questions that have been not answered. I want to thank the members for the active participation, and also to thank our speakers from Jhpiego for the beautiful presentations. I also have some good news. The early bird registration for the Global Digital Health Forum has been extended to October 13th. So you have about 2 weeks to grab the early bird tickets price. Our next webinar will be in October on the 12th. Kindly join in. It will be about information security for international development projects, and we'll be hearing from our colleagues from Palladium. I also want to urge you, for those who have not yet joined and signed up to the Global Digital Health Network, please join, sign up, and encourage all your friends, all your colleagues to sign up to this wonderful network of colleagues using the link that's been provided. Thank you so much, and I wish you a wonderful day. Bye.